morning, everyone. We're going to get started. So welcome to day 3. We've had 2 wonderful days of fantastic talks and great discussion, and hopefully you've enjoyed the food for those of you that joined us last night. So we have got some exciting sessions to start off today, and I will hand it over to Jeff and Mike to kick us off.
Great. Well, thank you, Laura. I'm Jeff Mechanic. I'm one of the moderators and very pleased to introduce this session. And I will turn it over to my co-moderator, Mike Lean, who will do the introduction.
That didn't sound like an introduction to me.
Now you know why.
My name is Mike Lean, as Jeff has mentioned, and you can understand that this has been a highly rehearsed introduction to the session. And my joy is to introduce the speaker, I think. And the speaker is Herzl Gerstein, who rhymes with lean. And we're delighted about many Europeans here would not know that. And Herzl has been a figure, a name in our reference lists for really quite a long time. He's director, I think still the director of the Public Health Research Institute at McMaster. And his most highly cited paper is from the Accord study, which told us not to screw down blood glucose with dangerous drugs made by drug companies. And now he's trying to relieve the drug industry by a new title, which is Can Pharmacotherapy and Lifestyle Together do a better job in achieving remissions of diabetes? So we all agree that remission is perhaps a good idea, but don't do it with dangerous drugs. So I think you better come and tell the story yourself. And I am delighted. I have never actually met Herzl before, and this is one of the joys of coming to a meeting in a funny place like Canada, to be able to meet people who are rare in Europe. So thanks very much for coming, and we're dying to hear what you have to say.
Well, thanks very much for the introduction. It's a pleasure to be here, and I almost wasn't here, as John and Laura heard, because, 3 delays in the flights and, had to change the equipment. But anyways, I got here. So it's a pleasure to come. And I think this is my 2nd or 3rd meeting of this group that I've been at. So as you just heard, I'm going to discuss the title on the slide, which is diabetes remission and the role of pharmacotherapy and lifestyle in combination for achieving a type 2 diabetes remission. These are the companies with whom I've recently worked to help improve the lives of people with diabetes, and worked in a very constructive way with. So the outline of my presentation is going to be a bit of a Cook's tour, and I'm going to focus on the actual title results in the last sort of half of the presentation. But I just will remind everybody of the burden of diabetes, and then the rest of the presentation will go from there. So this is the future if you happen to have diabetes, either type 1 or type 2, but we're talking about type 2 diabetes. So people with diabetes have a higher incidence of, or develop, compared to people without diabetes, everything on this slide more commonly than do people without diabetes, either at an earlier age or they just develop it and the other people don't. So, most of them for most of them, diabetes independently predicts them. So diabetes is still the most common cause of adult onset blindness in the world. And there are many things that everybody knows, and there are things that people don't necessarily know. So diabetes increases the risks of all cancers, except prostate, by about 30%. Pancreatic cancer by about 300%. Diabetes is a very important and independent risk factor for cognitive decline. I mean, we all know about amputations and kidney disease and kidney failure, nerve palsy, and claudication, all these other things. But the notable thing about this slide, and I always show it, is to remind you that everything on this slide is of interest to people who read the New York Times and the Globe and Mail. The word blood pressure doesn't exist there. The word glucose intolerance isn't there. Those are not of interest to the public. Diabetes increases bad things, and your mom and dad and kids will be able to understand all these things. It's a serious problem. And that's why in the United States last year, it's what, $350 billion a year of direct and indirect costs. So yes, diabetes has a very high burden of it. But the burden of diabetes, which people don't discuss and don't talk about, which I think is the most important burden as a clinician, and the most common burden, is guilt and shame. If you happen to have diabetes, you are probably at some level feeling a little bit guilty that you somehow brought it upon yourself, which is absolutely not true. People do not cause their own diabetes. And that is something I still see newly diagnosed patients with diabetes, not many. Most of my patients I've seen for years, or if they're referred to me with established diabetes. But I can probably predict with high certainty that there's at least a 50% chance when I tell that to a patient, you have diabetes, but you did not cause it, they break into tears. I have had more episodes of people crying. Why? Because everybody in their family, including their spouse and their doctor, has told them, I told you, and now you have diabetes. So in this day and age, I can swear that's bullshit. Diabetes is, you don't cause your own diabetes. Diabetes occurs for complex reasons. It's interaction between who you are and the environment in which you live. And you don't have as much control over what you do on a day-to-day basis as you think you do. Our environment does a lot to do that. So, how do we treat diabetes today? Well, we've had many, many advances, but to a large extent, the diabetes therapeutic paradigm is still a treatment to failure paradigm, where we put people on therapy and we wait and it fails. And then we put them on another therapy and we wait and it fails. And that's very frustrating for people. And they also feel that they're responsible for its failure. And this implications of this treatment to failure mindset that really pervades how we teach diabetes and how it's managed is that a diagnosis of type 2 diabetes is the beginning of a lifelong, increasingly complex journey of failure and ever-increasing complexity and cost. Thankfully, some of the new drugs that we're having may break that paradigm. And I think that that is really great. And this, what we're talking about today, has an opportunity to break that paradigm. But I think it's true. And there's lifelong labeling and stigma, which I've already mentioned. There's exposures to the harms of hyperglycemia, and glucose is toxic at high levels. It's life-saving at normal levels, but at high levels, it's toxic. Not many of our therapies cause hypoglycemia anymore, thankfully. And then there's, non-adherence. You put people on therapy, they don't take it, and they feel guilty about not taking it. So that is the story. So when I've given talks like this, the question I'm almost often asked is, well, you talk about remission, as do other people here, but why are you talking about remission? We know how to prevent diabetes. Diabetes, is a preventable disease. And I'm quite excited by that. When I've been practicing medicine since 1981, and I was quite excited to do one of the largest studies that showed you can prevent diabetes, published in 2003 or 4, 2005 actually, and there have been many. And in 2001, we would say, wouldn't it be great if we could prevent diabetes? I mean, there was a diabetes prevention program. First, there was the Finnish program, which was published, and then the US DPP. Then we did the DREAM trial, and then there were other trials. But after the Finnish diabetes prevention study and the US DPP was published in 2002, whoo-hoo, we can prevent diabetes. So you're a bunch of clinicians. How many of you prescribe drugs to prevent diabetes? Some, right? If you ask this to a group of family doctors, almost nobody. Despite the fact that metformin costs nothing almost, and you can give it to people and proven to reduce the incidence of diabetes by 30%. People don't do it. So in 2021, 20 years later, after 30 different randomized controlled trials of lifestyle, of drugs, of different types of drugs, of combinations, all of them, every one showing, including insulin short-term, every one of them showing that you can prevent, delay diabetes, nothing. It's not out there. Why? Why? And well, let me, before I even get to that, why? Not only can you prevent diabetes, if you prevent diabetes, there's a good chance that you're going to prevent bad things that occur in the wake of diabetes. So this analysis of the Ching study, which was a diabetes prevention trial in China, published in 2000 and I can't remember, 5 or 4, 580 people allocated to either control, nothing, or diet and lifestyle for 6 years. And then after the end of the 6 years, they were followed for 30 years. Those who were in the treatment group, who had a reduction of diabetes, but this is by an intention to treat analysis. If they happened to be in the treatment group, they ended up having a 50% reduction of retinopathy 30 years later, or a larger composite outcome, and even more importantly, a reduction in cardiovascular events by 25% or all-cause death. So preventing diabetes has benefits. Despite that, we're still not prescribing drugs to prevent diabetes. Why? Well, I've come to the conclusion, and I think many have, is that when it comes to type 2 diabetes, prevention is for populations, not for individuals. Because, you know, Dr. Gerstein, I've been on the statin for 30 years and nothing's happened. That's the point. People don't understand. It's hard to tell people, take a drug for something you don't have, because you will then be holding a lottery ticket, which is less likely to pay off, which is really what prevention is. You know, you're giving people a lottery ticket that's not going to pay off as much as if they didn't have the lottery ticket. And that's a hard concept for many of our patients. So I think, but if a person has the disease, the motivation to do something about it is much different. It changes the whole psychology. So remission is an individual patient issue. Prevention is a population issue. It's changing the environment in which we live. You don't change the person, because you can't change the person's composition, but you can change the world in which they live. And the diabetes epidemic did not happen because people changed, because the environment changed. So that's part of the story. So is remission possible? Well, before we decide if it's possible, we have to define it. There are 2 definitions of remission. The major one was, I was part of this consensus group several years ago, and that was the ADA EASD group together. And then there was a Canadian iteration of it, and they're almost the same. The difference is, in the American and the European definition, you need an A1C less than 6.5% at time 0, and another one 3 months later, less than 6.5%. And if both of them, and if in that interval there's been no glucose lowering drug, that's called remission. In the Canadian version, you don't need the one at time 0. You just need one at 3 months after no drugs that are less than 6.5%. So they're almost the same. That's it. Now, and that is a working definition for remission. It's being criticized by many people. What do you mean 3 months? Well, my defense of that, strong defense of it, is you have to create a working definition to then motivate researchers to target it. Nobody cares about 3 months of remission in 50 years, but we're not going to get to lifelong remission in 50 years if we can't get to 3 months of remission today. When I finished medical school, if you had acute myelogenic leukemia, you were dead in 3 weeks. Nobody went from that to now having a life, a prognosis of 15 years at bone marrow transplant, or 20 years, et cetera. You went from 3 weeks to 6 months to, right? So you need to go somewhere so people do the research and then push it and push it and push it. So I like that definition because it enables the research to get done. And then you can push it farther. Spontaneous remissions using that definition occur. So here's an analysis of a registry study. that 60,000 people with diabetes, mean age was 65, just followed by 2 years, 12% had 2 consecutive A1C levels that were consistent with remission. That's 10% of people with newly diagnosed, with type 2 diabetes, not necessarily newly diagnosed, with an established diagnosis of diabetes. So remissions do occur, spontaneous remissions. And here's another one, a sub-study of the cluster randomized addition trial. 867 people in a UK-based study, 20% had remission after 5 years. Now that was a randomized control group, so there were different population. The previous was just a registry study, so probably more reflective of the population. In that registry study, those who developed remission were 25% less likely to report diabetes-related consequences later on. So, so remission seems to occur spontaneously, and if you go into remission, you're better off. That's not a randomized trial, but it's consistent with the hypothesis that remission may be good for you as far as outcomes. So what therapies can achieve remission? Well, I am not going to review all these, but I'm just going to be, for completeness, show them. You know who rekindled the interest in remission? It was the metabolic surgeons. It was general surgeons who could not do vagotomy and pyloroplasties anymore because ulcer disease was cured. They need another reason to invade the abdomen, so they did bariatric surgery. And I mean that as a bit of a joke, but actually, thank goodness they did it, because they taught us that 50% remission, 60% remission in people who have bariatric surgery for obesity, who happen to have diabetes, and now it's called metabolic surgery. Great, wonderful. We learn from everybody. Just because you're a surgeon or a physiotherapist doesn't mean you can teach the world something fantastic. And they did, and that is really wonderful. So that motivated everything. And that's great. But if you can do it with a knife, can you do it with a pill? Can you do it with a food? Right? And so that's the metabolic surgery. What about lifestyle modification? Well, there was analysis of the Look Ahead study, which was a study which did not show that intensive lifestyle reduced cardiovascular events. But interestingly, they did show, this is a study of 5,000 people, 4,500 of them did not have anything that would be called remission at baseline, and they were randomized to intensive lifestyle therapy versus control. And the mean age was 60, about half were women, a little bit more than half were women. And the intervention group had behavioral approaches, frequent visits, reinforcement, tools to follow an 1,800 calorie diet or 12 to 1,800 calorie diet, brisk activity, and followed for 12 years. And they defined remission as no diabetes drugs and an A1C less than 6.5% on 1 or more follow-up visits. And they also looked at incident cardiovascular disease, was MACE or angina, and incident CKD, which was a face validity, good definition of that. And at the end of 1 year, those who were in the control group, you can see, which is in the black, had much less remission in that definition than those who were in the intensive lifestyle group. So at 1 year, it was about 11% versus 2%. And at 2 years, it was about 10% versus 2%, right? So you see, very, very nicely, intensive lifestyle group did achieve a remission in those people in this randomized controlled trial. And if you look at those who were in remission for no visits, those who never got remission, there was a lot of outcomes. And as the more visits in which there was remission, there were the hazard of serious kidney disease outcome or cardiovascular outcome went down. So remission, again, achievable in RCT. And if you got remission, this is not quite a randomized analysis because it was just in the remission group, but at least it supports the hypothesis that remission could reduce serious outcomes. Now, what about very low calorie diets? I am not going to discuss that right now because everybody knows about the direct study and everybody knows, and I'm not going to stand up here beside other people on the podium and even say a word about that because clearly they work. Very low calorie diets, replacement diets for a period of time, followed by reintroduction of food causes remarkable remission, and which can prolong for 1 or 2 years' time. But most of our patients are not necessarily going to do that, but it certainly does work, and there's no question. And it's a real gift to the world that those studies were done, because it's changed the way thinking, and it really, that together with metabolic surgery really helped make this mainstream issue. So congratulations for that. That's part of that. What about intensive insulin therapy? Well, when I was a medical student, we knew this. We used to, in the 70s, you'd see people hospitalized with newly diagnosed diabetes, and they were given insulin IV to control their glucose levels perfectly, and then they were sent home without diabetes. David, you might remember that. There were some of these, you might, right? Remember that? And then that kind of died away. And then there was a poorly done study in China about in people on pumps that was not well randomized and didn't do that, but suggested that might be true. But there was a recent study, not perfect, that actually looked at that, a Korean study with 100 people with newly diagnosed type 2 diabetes, 8 different sites, randomized to either intensive insulin with glargine and glulisine, intensive insulin therapy versus glimepiride and metformin. And they were followed. I'm not going to talk about the details, but at the end of a year, 2 years, pardon me, you can see that about 50% of the people in the intensive insulin therapy group were in a remission, compared to about 20% or 25%, 30% in the conventional approach. The problem with that, if you look at the bottom, 71% retention. So we don't know what happened to 30% of the people. So, but that's fine. That's, suggests there might be some smoke there, maybe fire there. There's smoke there. There might be fire there as well. And then multimodal approaches, which is what we've been focusing on in our group. And the multimodal, approach is, let's see if we can combine diet with drug therapy and some sort of cocktail to do it. And this is a paradigm which we took from cancer and from autoimmune diseases. So if you have cancer, you give people lots of drugs, and you then, take them off drugs. You put them into some sort of remission by exposing them to lots of drugs intensively. Then you take them off and you follow them, and you see how they do, and some relapse and some don't. Same with some autoimmune diseases. You can do that. So we said, well, if it works for cancers, and the prognosis of diabetes is worse than the prognosis for many cancers, newly diagnosed type 2 diabetes carries a worse mortality risk than newly diagnosed breast cancer, all comers. I'm not talking about metastatic. So diabetes is a horrible disease, just as bad as cancers. And if these approaches work for cancer, maybe they'll work for diabetes. So we talked about, and second thing about cancer, you should not talk about cure. We talk about remission. All chronic diseases go into remission, don't cure. You don't talk about curing lupus. You don't talk about curing Crohn's. You put into remission. Diabetes is the same thing, right? And you don't talk about curing breast cancer, time-limited use of drugs, etc. And then, so the hypothesis is that a therapeutic cocktail that combines lifestyle coaching and drugs may rewind diabetes and maybe promote a remission. And who knows? It was a hypothesis. You got to do trials. So we actually started doing, we have now done 5. We did a pilot study in 2015 funded by Diabetes Canada, and then 4 others where we got pharma companies to give us support as investigator-initiated studies. This is the REMIT series of trials. We've published all 5 of them now. And this is a program of type 2 diabetes remission trials, and they're all designed the same way. We take people, we recruit them, we then randomize them after a week time to either standard care, continue what you're doing, or induction therapy, put you into remission with 3 to 4 months of an intensive therapy approach, after which we stop the approach and then follow them. And the people we've recruited for all these have had diabetes less than 5 years. So we did this in people that have recent diabetes, less than 5 years, and not on insulin, people who are on oral agents or nothing, drug naive or oral agents, diabetes less than 5 years. The intensive approach we would do is we would give them all basal insulin to normalize their fasting glucose level, less than 5.3. Less than or equal to 5.3. All of them got metformin, and then all of them got a third drug. In our pilot study, that third drug was acarbose, because that was cheap. And then in the subsequent studies, we did dapagliflozin was a third drug, metformin was a third drug, lixisenatide was a third drug, or liraglutide was a third drug. Those were the 5 trials that we did. And so we did that, frequent visits every week for the first 3 months, and then phone calls intermediate. So not just the intervention with drugs, but hand-holding. We hand-held the people in the study, very frequent visits. So very intensive, phone calls or visits for the first 3 months of therapy. And at the end of that, if their A1C was less than 7.3%, we stopped their drugs, regardless of what group they were in. Both the standard care group and the other group, the A1C is less than 7.3. We'd stop their drugs and follow them by doing A1Cs every few months and seeing them and see who is we assumed you were in relapse. If your A1C was you're in remission, pardon me. If your A1C was less than 7.3% at 3 months, then we stop the drug and then we see how often do you relapse, defined as an A1C greater than or equal to 6.5%. So, and that was relapse criteria, either glucose level went high or use of glucose drugs or A1C went up. And we followed them for only a year time. And here's what they showed. Okay, so here's the pilot showed that it was feasible, and we had, I'm not even sure the pilot. This is our first one, which we used dapagliflozin, and you see that there was a 43% reduction in relapse and remission at each time point, 24, 36, 48, 64 weeks was certainly more in the treatment group, in the induction group than in the control group. Yeah, there's a failure rate. Of course, there's a high failure rate. But this was, insulin targeting normal glycemia for 3 months, plus metformin, plus dapagliflozin versus standard care. So all those three, plus lifestyle, plus, and we told them, we tried to lose weight, and they lost about 3% body weight loss, plus lifestyle, all that versus just standard care. So we just put the whole cocktail in. We were not testing DAPA separately or metformin separately. It was all of them in one versus nothing. Same thing with sitagliptin. It was a smaller study, only 100 people in this one. And you can see that, the curves don't look as pretty, but there's still an effect at the end of 40% reduction. And at each time point, there was an effect. We did the same thing with, I'm almost finished, relapse, with Iglar-Lixi, same thing. The last one we did with liraglutide, not quite as nice. And so, we didn't see it. You do trials, you don't always get what you think, and that's fine. But you see that there was a shorter effect that did not seem to be anything sustained for a year's time. Those were the 4 trials that showed there. 2 more slides. There was another trial published recently this year of dapagliflozin alone plus calorie restriction. It was a Chinese study and followed for 14 months. Just to jump to the thing, those who had dapagliflozin versus remission for a period of time and then it was stopped seemed to have a 50% more remission rate. And that's supportive of the dapagliflozin study, but that's where we are right now in that. And finally, the last point I'm going to make is, what about other therapies? So there was this analysis from the SELECT study, which was a study done in people without diabetes. This is an obesity study in people without diabetes randomized to semaglutide versus placebo. It reduced cardiovascular events. But Steve Kahn did this nice analysis saying, did semaglutide cause regression in people who had dysglycemia, cause regression to normal glycemia? So in the SELECT study, 2/3 of the people in the study were IFG, IGT. Well, they didn't do glucose tolerance. 2/3 had dysglycemia. They had an A1C that was above 6 or 5.7 if you're an American. And if you can see at baseline in the SELECT study, which is right here, all participants, about 30% were normal glycemic, and the orange here, about 60% were dysglycemic at the beginning of the study. And those who were randomized, you can see those who were randomized to semaglutide, the proportion of normal glycemic people went up at each time point. So not only did semaglutide prevent progression to diabetes, it actually promoted regression to normal glycemia from dysglycemia. These are all participants, and here is just restricted to the people who had dysglycemia by Canadian criteria and European at baseline. So, and compared to the placebo group here. So the point is that maybe a maintenance therapy, with cancer, you put people into remission, then you try to keep them in remission with maintenance therapy. Maybe a GLP or something like that is once we achieve a remission, even in the direct study patients, maybe we should keep them in remission with a drug like a GLP-1 receptor agonist. So final points, primum non nocere. People are not the cause of their diabetes. They are part of the solution, and that may include attempting remission when it's feasible and possible. But it's important that we don't substitute guilt and shame of a diagnosis of diabetes with guilt and shame of not achieving remission. If you can't achieve remission, that's not your fault either. We're doctors, we're not, priests. We're not here to tell people they're going to rot in hell, right? We are here to say, we want to do the best for you. So guilt and shame should not be part of the discussion at all. So it's really important we keep that in mind. Type 2 diabetes remission is achievable and is an option. The evidence continues to grow. Perhaps 30 to 4% may be able to achieve it today with today's technologies. For a while, using unimodal approaches, maybe multimodal approaches. I do not claim for a minute that the studies we did are the answer to anything. I claim that they're like the first breast cancer studies. They're better than nothing. We're moving forward, and you got to start the journey. It's a Chinese saying, the first step is the beginning of a long journey. Take the first step, or something like that. I wrecked it up. Future innovations must increase the proportion of successes, broaden eligibility, prolonged remission duration, reduce relapse rates, and test and include effective regimens. And the prediction, remission, diabetes will not have to be forever. So thank you very much for your attention.
This is a tremendous talk, pleasantly provocative.